Welcome to the virtual Infectious Disease Congress sponsored by Johns Hopkins University School of Medicine on ID Care Live. My name is Rachel Gottbaum, and you are tuned in to a live CME session called Infectious Disease Game Changers with Dr. John Bartlett. Dr. Bartlett is a professor of medicine and epidemiology in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. Before we get started, I would like to remind you that we will be taking your questions in real time throughout each presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen. You're on, Dr. Bartlett.
Well, thank you, Rachel. So I'm going to, this is a completion of the talk I gave this morning. These are going to be the topics that I didn't talk about this morning that I chose to talk about this afternoon. So we're going to start with sexually transmitted diseases. And the elephant in the room is the gonococcus because of resistance. It's always been a big one, but it's a big one now in part because it has this penchant to develop antibiotic resistance. So we're kind of down to ceftriaxone as possibly the only drug left. And that's because cefixime is no longer recommended because of resistance. So this is where the ceftriaxone resistance has been found in the United States, or the cefixime resistance has been found in the United States, mostly gay men, mostly West Coast, but we know from past patterns that when it's on the West Coast, it comes east and it becomes generalized. So here are the sort of the sequence of events with the gonococcus, just pointing out that no matter what you throw at it, it will learn to get around it. So going back to 1937 with the sulfonamides and then penicillin and then an increased dose. And then the resistance problem with ceftriaxone and cefixime and Cipro, Levo, Oflux, and all the fluoroquinolones. And now we're left with ceftriaxone as the only drug left that we can give, and of course it's IM, and that becomes a bit of an issue in terms of our easily handling the disease. Now, fast forward to a very recent and colorful report by Jerry Groopman in the New Yorker magazine. And I urge you all to read this because it's a fine read as well as fine science. But he tells the gonococcus story that I just told, but he finishes up with the punchline, which is ceftriaxone is the one drug left standing. However, we already have resistance to that drug. And so this is a prostitute in Kyoto in Japan who had pharyngeal gonococcal infection, and it did not respond to ceftriaxone, so they gave her another dose, and that did not respond. And the conclusion of the story was that she had ceftriaxone-resistant GC. And now the same identical strain by molecular typing has now been found in France and Germany, and I'm now told there are 7 out there. So this infection, which is highly prevalent in the United States and the world, 700,000 cases a year, is now becoming very difficult to manage and likely to become more difficult.
So were they able to treat those cases or not? You can't treat them because they're resistant to this last drug?
Well, there's probably going to be some way to get at them still with drugs like spectinomycin or maybe gentamicin. I mean, there are some long shots that have not been used very much, at least not recently, that may bail us out. But this is the resistance story, Rachel. I mean, we just keep using all the drugs we've got, but now there's no pipeline, and we wind up with nothing, and we wind up with bugs we can't treat anymore. And that's really scary, especially for something that is such a huge public health problem. Okay, human papillomavirus. Those of you who heard Neil Halsey a little while ago spoke a bit about this. These are the recommendations for the use of that vaccine. And it's, of course, advocated for girls and boys before sexual debut in the United States. And going up to age 26 with particular emphasis on MSM because of the risk of anal carcinoma in that category. So this is sort of the sequence of events in Australia. Now, I show this because Australia knows how to do this. Australia makes the quadrivalent HPV vaccine available in the schools, government supported, therefore easy to get, and no cost. And the uptake is 70–80%. And what this single report shows is that although the program's only been in process for a few years, they're already seeing some substantial changes. And one of them is the remarkable decrease in genital warts. They're down 90% since the implementation of the vaccine. Can you imagine that? Now, some of you are going to say, well, genital warts, that's not cancer. Well, okay, but I can tell you, if you ask a teenager if they worry more about genital warts than cancer, they're going to say genital warts. They don't want genital warts.
But how is that different than what we do here in terms of the vaccine now?
Oh, because our uptake is pathetic compared to theirs. Our uptake is probably 20%.
Well, why?
Because they give it away, and they give it in schools. How do we do it? Well, I think I have it on. Oh, this is the curve that shows the decrease, but I may have had the price tag. No, I didn't have the price tag.
So basically, we make it more difficult
Oh,
because
we
we're doing
make it more difficult,
yeah.
and we also don't make it free, and it's pricey. It's expensive. It's an expensive vaccine, and you got to go to a doctor. I mean, you know, all that inconvenience.
Yeah.
You know, we tell parents, your kid should get this, and yet we make it hard for them.
Right.
And that's why I sort of like the Australia approach to this. This is the cancer data out of Australia, and I thought it was interesting. It's obviously very early because cancer takes a long time. And we're talking about kids.
Right.
Well, they're kids to me. they're kids to me. But what I wanted to show here is that you can see that there was a difference when they gave the vaccine to the girls under the age of 18, but not above that. And the reason was they waited too long because they already had the papilloma virus infection.
Why would they give the vaccine to somebody who already has it?
Well, they don't test for it.
They don't. They just give it. Okay.
Yeah, it would be very expensive, but it's a good question.
Okay.
And this is kind of the same thing, except it's in men, and what it's showing. The placebo group does have the anal intraepithelial neoplasia changes, and that's in the placebo group, and you can see that's increasing. But I would emphasize the fact that this is very early after the vaccine, and to show this much difference in a rate of cancer or precancer is pretty striking. And of course, the place where they need this in this area of the world where they can't afford it, which is, the developing world. This is cervical cancer is 25% of female cancers in most of the developing world. Now I'm going to go on to talk about HIV infection. The picture, by the way, is a picture on the cover of JAMA that was devoted to HIV care. Now, most people, when they look at that, say, what do you think that is? And they say, I think that's a virus, an HIV virus. And the painter, the artist who did this, said it has absolutely nothing to do with the art with HIV. That is the inspirational issues around what has happened in the field of AIDS. That is inspiring. It's not a bug.
Right. Right.
It's inspiring.
That's right. We've come to that point
We've
now.
come to
That's
that
right.
point.
We've come to that point. Okay.
And so I just
Right.
read the thing from Hillary Clinton that says we've got the ammunition to put it away. Okay, so here's the test. So I'll start out by saying something about the testing. The testing is undergoing a change. Now, I think everybody that's listening to this probably knows what we have been doing specifically in the past. We have stressed, this is the CDC, this is Bernie Branson. We have previously stressed specificity. In other words, we did not want to make an erroneous diagnosis. Mr. Jones, you have HIV infection. No, he doesn't. That would be awful. False positive tests are virtually zero. We just don't get fooled with false positive tests. So the issue now in 2012 is sensitivity. And what that means is a movement toward the fourth generation test that tests both the antigen and the antibody, so you get it faster. I'm not going to show you all the algorithms. In fact, I'm not sure they've really decided quite yet how it's actually going to go. A couple of things that are on the slide that I should mention. The the CDC, as I think everybody listening knows, made the recommendation that everybody should be tested between the ages of 13 and 64, and made that recommendation in 2006. In 2007, the United States Preventive Services Task Force, another federal agency, gave a recommendation that was totally contrary to what the CDC said. So you've got two government agencies telling you completely different things.
What was happening there?
Well, we don't know, but we like the CDC and we don't like the U.S. Preventative Health Service Task Force. But the good news is the U.S. Public Health Preventative Services Task Force went the CDC way in 2012. I put rehabilitated under.
Okay,
they
good.
got rehabilitated.
That was a euphemism. Okay.
But I think that sort of begs the issue. What did we learn between 2006 and 2012 that would change their mind? And the answer is nothing.
Well, what about these in-home tests? And also, you showed us a picture of the people taking an HIV test in a kiosk in an emergency room. Do you think these at-home tests are a good idea?
Oh, this is not about the home test.
Right.
This is about just getting tested.
Right.
I'm going to talk about the home test in a minute.
All right. I can jump the gun here. Okay.
So here's what you were talking about. This is the way. So that's a big valley. The big valley is this.
Yeah.
There's a lot of patients, 30% of patients, that get the screening test and never
Right.
show up for the confirmatory test.
Right.
So this is the valley of death of knowing that you've got HIV infection, you have positive screening tests, but never get the follow-up. So what they're saying is you ought to get the fourth generation test as soon as it is FDA approved. Now there is one, the Architect test, is available in your laboratory, so you can get in the laboratory. And there's also, but most of us like the point of care test because you can do that in the emergency room and so forth.
Right.
There will be a fourth generation test available in the near future, probably Determine or one of the others, but it will be available. And the advantage is on the right-hand side of the slide. First of all, you get immediate results. We can get that now, but we can't get it for both the antigen and the antibody. You can detect early infection, that's because you can get antigen. And specificity is not the issue. And there is an algorithm that will be used in interpretation of the test. But notice on the left-hand side, the recommendation is to take that patient who has a positive screening test by the ear to an HIV care clinic. They ought to go directly to the clinic because we lose a lot of patients. That's part of that Gardner cascade. Here is the test you were asking about.
Right.
This is the Oraquick test that's now available in drugstores. It's all over. I think 334,000 drugstores. It costs about $40. Notice the sensitivity. It's 93% sensitive. And I think a lot of people in science would really wish it was a higher sensitivity.
Of course.
Because, you know, if the patient says, well, I had a negative test, then I can say we got to remember that 1 out of 12 is false negative.
Right.
And so if you really want to know, you may have to get a different test.
Right, right.
And Magic Johnson's on there because he endorsed it, and he's always been magic to me.
Yeah, well,
that guy is easy to love.
Well, let's hope he's working it now. So,
Okay, now let's get into the cost of care. Most of the cost of HIV infection is for the drugs, and I think people know that. So it's 72%. You notice the provider, I thought the audience probably like to see that, we get 2%. So anyway, the economics is very heavily, and of course a lot of us are concerned about how we're going to fund HIV care in the future as we test more people and have more survivors, so we have an increasing pool of people who need care.
but are the costs of the meds coming down?
Well, that's what I'm about to talk about. First problem is that HIV infection, more than any other disease that I know of, selectively hits poverty.
Right.
So the rate in poverty is as high as many countries in Africa. And that's what this shows. So a very expensive disease in a population that has very little in the way of resources. Now, of course, we're going to have the Affordable Care Act, and that may take care of some of this, or all of it, or most of it. It won't take care of the immigrants, the illegals. We will also have the possibility, of course, that we'll still have MADAP. Well, MADAP is ADAP.
Right, ADAP, right.
ADAP program. It's MADAP in Maryland,
Right,
so
right.
that's what I call it.
Right.
We don't know about that. I was at a meeting yesterday with Secretary Sebelius, and the answer is we don't know. We just don't know.
So what you're saying is you don't know who's going to pay for these medications, is what you're saying.
We don't know.
Okay.
But notice on this line, which is the time the U.S. patent expires, and notice that we're very close with two really key drugs in terms of usage. 3-TC is already off. Abacavir's about to go off or off. And efavirenz is about to go off. Now that will require a breakup of a triplet, for example, the one pill once a day. And you know, that was really, as most of the people listening know, that was really magic. I mean, when we got down to one pill once a day, that was eureka.
Right, that was.
But it was reviewed by Rochelle Walensky, who's probably the best person to do this, and just published, by the way, in the Annals of Internal Medicine. And what she said is efavirenz plus 3-TC plus tenofovir.
Right.
If we use that instead of a tripla, we would save the government almost $1 billion a year.
Because they're generic.
Because 2 of the 3 are generic. Now, I'm not going to weigh in on this because I can see both sides of this. But you know, if you've got an ADAP that's got 10,000 people waiting for drugs, you know, like Florida and Georgia and some of those places, and they can't get treated at all, you may have to say, you know, we're going to have to start doing something different.
But you're also dealing with the catch-22 of compliance. I mean,
I know. It's a very tough issue. But the reason I presented it here is because I think it's one of those things that we're going to have to address. And you know, with Lipitor and with other drugs, well, when you go to the drugstore and say, we're not giving you that, we're giving you this. Because we think this is as good as that.
That's right. Right.
And they don't care if you take 3 pills or 1 pill.
Right.
They don't care if it's big or small.
Right.
That's the rule in pharmacy in the United States.
But in the case of what you use Lipitor for, you're not going to develop resistance if you don't take these drugs correctly.
No, it's a very good point. I don't know how effective we're going to be in waging this argument. Everybody's worried about healthcare costs.
But why are we still seeing such an increase in HIV infection? I mean, we are, right?
We've had 50,000 new cases a year for 20 years.
And we can't change that. We don't.
Well, I'm getting there.
Oh, okay. Once again, all right.
Did want to call attention to the fact that the United States is the only country in the world that recommends antiretroviral therapy for everybody. And that's what it says. It says blanket. It's not modified. There's no asterisk. Everybody ought to be treated. Now, some people aren't quite ready and they have to get ready, but I think this simplistic statement is very important. And here are the new drugs, or the drugs that we have, 26 drugs. And the red one at the bottom is red because it's not yet FDA approved. It's dolutegravir, and people are excited about that drug. The one that's newest, of course, is the quad, and people like the name. They like the size of the pill. They like the 1 pill once a day.
Right.
And I think people are enamored of the quad in general. But I think other people have heard a lot, and most of the people have heard a lot about this pill. Dolutegravir also looks very good. And I'll just say that in this big trial with efavirenz-based tart, why it did very well. In fact, a bit better.
So good news on the HIV front for meds.
Well, yeah, but the pipeline is slower. And there's no question that it's slower. It's not like hepatitis C. There's also a great deal of interest in PrEP, that is pre-exposure prophylaxis, and taking patients who are at high risk but not infected and giving them the pills. We've sort of beaten these 4 trials to death. They all seem to show efficacy. I think I kind of summarized it here. The efficacy is between 62 and 91%. But a lot of it depends on whether you take the pills. You know, if you don't take the pills, they don't work. they just don't work.
Yeah. It's a Russian roulette trial, this trial.
Yeah, and so but I think we can say that it will work. We were worried about resistance, but notice there were only 3 resistant strains out of 3,000 strains that were tested. And actually, it turned out that they may have been there before the drug was given. So the resistance is not turning out to be much of a problem. Short-term toxicity is not an issue. Long-term toxicity may be an issue because we haven't used the drugs long enough to know that. Now, my concerns about PrEP, I'll express here. I think people are worried about the long-term toxicity, resistance, adherence, and cost. And so I'm not going to say the obvious. What I worry about a little bit is about PrEP as a public health way to deal with this infection. What I worry about is the person who has high-risk behavior but actually uses condoms, is fairly careful, but wants to take a risk of 1 in 1,000 to 1 in 1,000,000, and is very compulsive about health and whatnot, and really seeks this, and maybe deserves it.
Right.
But the ones we want are the ones that are poor, down and out, and don't access care now. I mean, that's where the epidemic is. That's why I mentioned the poor people. I mean, we're not reaching a good number of the people that need it the most. So it's not only true of the patients who have AIDS, it's the patients who are most vulnerable to AIDS. And then that's why I worry about it as a public health
So
issue.
on the one hand, you're worried about access. What you're saying is you're worrying about access of these drugs. But on the other hand, are you also saying that people may be taking more risks because the message is you can take these drugs or you can take drugs? I mean,
Yeah.
once again, it's a little bit of a bind, is it not?
Yeah, we worry about what they call inhibition.
Right.
So that people will take
And have
more
the studies
high risk.
shown?
And there's also the possibility of street value
Right,
of those drugs.
right. Oh,
Yeah,
right.
yeah. So there are good ways to deal with the issue of the person who takes it in terms of making sure that they haven't already contracted it, that they're not taking 2 drugs instead of 3
Right.
for an already acquired infection. I mean, those rules by the CDC I didn't put here because I think they're too long and most people know what they are.
Well, how do you get access? I mean, why?
Well, you'd have to come to somebody like me and say, I don't have AIDS, but I don't have HIV infection, but I'm worried about getting it. So then I would do the test.
Right.
I would find
Right.
out what the risk was. I would do the assessment. That person has to come back every 3 or 4 months, get tested again, get tested for sexually transmitted diseases, get tested for HIV.
So it's like any healthcare issue. The poor don't have access to healthcare, so that's why you're raising
Well, of course,
this. It's
under
not.
the new health care law, they would have. I don't know if that's going to happen. This is the Science Breakthrough of the Year, and this is Treatment as Prevention, and this is Mike Cohen's study. And here's the results. There was one transmission in that discordant couple analysis that he did in Africa. There's a couple of asterisks there, and the reason is because the person that, you see, I don't see how you can transmit this virus.
Under what circumstances?
I don't see. I think if you have gone to no detectable virus,
Right.
you can't transmit it.
Right.
Now, somebody's going to say, we never guarantee never in medicine.
Right. Right.
And I think that's right. Somebody's going to break the rule. I haven't heard of it yet, but I think somebody will eventually have no detectable virus and transmit. This particular person was positive on the first test after enrolling in the study, and they really think this person was positive before they got the
Okay.
pill.
Wow.
So it may be perfect. Now, by the way, one of the things that's important about this study is to know that it's still going on. They've changed it a little bit in order to comply with ethics, the ethical
Right.
needs.
Right.
But what they want to know is, now they know that it works. What they want to know is durability. And they also want to know what this will do at the population basis. And this is an area of Africa where they have very high rates of transmission. The green is high transmission rates and low access to antiretroviral drugs. And as you move across and get more yellow and red, the rates of HIV go down and the rates of antiretroviral therapy go up. So they have reduced the rates of new infections by 40% to sort of substantiate the Greenwich data, which says if we treated everybody, the virus would disappear. And that's what Hillary Clinton's talking about. Now, hepatitis C. I'm not going to say very much about hepatitis C, but it's probably, and in the field of infectious disease, probably the most exciting story. Here is the sort of the background data. There's 3 times more people that have this infection than have HIV infection, and this year it had more deaths than HIV infection did. So there's a lot of it out there.
Is that the first time that it's had more deaths?
Yes, it did. It just crossed the line.
So that's
Those
a big.
2 lines just crossed.
So that's a big story.
Yeah, it is. Hepatitis C is a big deal in the world and in the United States. The people that were born between 1945 and 1965 are called the baby boomers, and they have 75% of the cases. And if you ask them if they ever shot drugs, the answer is no, because they don't remember. That was that era where college kids, everybody in that kind of age group seemed to be wrapped up in that culture. So the CDC said we should test everybody in the birth cohort in order to find those people, because we now have great therapy. So what did the U.S. Public Preventive Services Task Force say?
I don't want to venture there now.
Oh, it was issued yesterday. They gave it a Category C, which means don't bother. Or think a long time. I know, and you know, and I know they'll change their mind. But in that 6 years for HIV, there were 300,000 new cases of HIV. Now, you can't blame the U.S. Preventive Services Task Force for those 300,000, but some of them you can blame.
But so essentially, are you telling the doctors that are, our audience here, that they should go with this and be testing folks and asking them to test?
They should be testing folks,
Okay.
yeah. But the third-party payers may squawk.
And that may change with...
Because they march to the Preventative Services
Right.
Task Force. It's a federal agency.
Right.
What we want to get with this is a sustained viral response. And this is the exciting part of hepatitis C. Hepatitis C learned a lot from HIV. And here is the sequence of treatment. So we go back to 1991 with interferon and then peg interferon, drugs that people just hate. They're awful.
Yeah.
In terms of toxicity.
Yeah.
But now look at 2012. There's somewhere between 37 and 76 agents at the FDA for studies.
That's amazing.
It's amazing.
Yeah.
We haven't had that many new antibiotics in the last 2 decades. And there it is. And it's going to be all oral. It's going to be pretty toxic, pretty well tolerated.
Right.
It will not be cheap,
Right.
because these are all new FDA-approved drugs, and they're going to have to get their investment back. So it'll probably be $50,000
A year, yeah.
a year.
Yeah.
One thing to remember is that when you get a sustained viral response, which they think most people will be able to get, that's a cure. Now, we can't do that with HIV. We can't do it with hepatitis B. We can cure hepatitis C.
So how long do they have to be on these drugs? You're saying that it's a cure. That basically they develop the antibodies and they go on their way?
No, they don't develop antibodies. They kill all the bugs.
And how do we know they're not going to come back?
I mean, it's like an infectious disease. It's like a lot of other infectious diseases. The virus is gone. You see, it's not like HIV. It's not inculcated into the gene.
So basically, if they take this for how long, this new drug?
Well, there's a whole bunch of new drugs, and the regimens are variable. I mean, they may be 2 months, and they may be 3 months.
And then they're done?
And then they're done. And here's one of the studies. It was actually done by my next-door neighbor, Mark Solkowski. And what it did was to take 2 different genotypes of the virus and 2 different genotypes of the host, which are very important in terms of response, and showed with 2 oral agents he could get 100% response. I can tell you, this is really exciting. This is really exciting.
It's a revolution. It's a revolution.
But
right?
we also have to say that the squeeze to do this depends on where. These are all experimental drugs. There's boceprevir and telaprevir, which are FDA approved now, but we're going to be getting better drugs. And the question, if you have hepatitis C, is do you have cirrhosis? How much liver disease do you have? And if you have cirrhosis, can you wait 2 years? Or do you need to be treated now? And they have ways to do that. It's all on basis of fibrosis scores.
Right, but what's the downside of treating people with the
Oh,
older
because
drugs?
it'll get better. Oh, the
Before we
downside
get the
is
good
they're
drug.
not as good.
But
They
if that's all we have now and you need to be treated,
Oh, no, you go with it.
you do go with it. So then
Yeah.
it's not a matter of delaying treatment.
Right.
Okay.
And I thought you'd all like to see this. It was the closing ceremony of the Eastern Liver Disease Conference, the Eastern European Liver Disease Conference. And I can't see it. You perhaps can't see it either. It's a hearse with interferon on top
Okay,
of it.
I definitely did not see the interferon part, but okay.
That's interferon.
Wow.
And that's the cheering.
Wow. Okay.
Because we can perhaps all get rid of that. Okay, for community-acquired pneumonia, I'm going to go through this a little bit fast. We just don't make a diagnosis of community-acquired pneumonia. What's on top is Bulwa back in the pre-antibiotic era. He got the pneumococcus back in pneumococcus most of the time, but he got a bug that likely to cause it. 4,000 cases, 98% had a microbe. Now, fast forward to 2009. We make an etiologic diagnosis in 7.6. This is 17,000 patients in American hospitals, Medicare data. It's good data. It's the best data we have. So we have really stopped, essentially. We just give antibiotics. And I think that's disappointing to people in the field of infectious disease. But nevertheless, that's where we
Wait,
are.
why are they disappointed?
Disappointed because we would like to know what the pathogen is to help build good or better vaccines and to be more pathogen specific in antibiotic selection. Right now, we give fluoroquinolones, the broad spectrum cephalosporins, and macrolides to almost everybody that has pneumonia. We may be able to do it much easier.
But are you saying that because we have been able to treat it, that we can't understand it in the way we need to be understanding it? In other words, if we're treating it, we're not following the pathogens and not figuring out which are our specific targets, for specific antibiotics?
Yeah, if we knew the bug, if we knew it was a pneumococcus, we would probably treat it with penicillin.
And why don't we know?
Fleming's drug.
Why don't we know?
Because we don't do the diagnostic tests.
So it's a matter of testing.
Well, there's been a sequence of events, but quite frankly, it's the same disease that Bulwa had. He really worked on it. People in 1917 really worked on getting that bug out. They even stuck needles in the chest to aspirate the pneumonia. People now say, Joe, here's a cough, and Joe doesn't cough and spit stuff in here, or it's all
Right.
saliva, and they come
Right.
back and they say Joe couldn't produce a sputum sample. When I was an intern, you didn't leave that patient until he gave you a good purulent specimen. It's gotten sloppy. So this is pneumococcal vaccines, and it goes back to the early days when we had Pneumovax, and then, of course, we had the protein-conjugated vaccine, Prevnar 7, and then more recently, 2010, we got Prevnar 13, and then more recently, in 2012, the FDA, so it was, the Prevnar 13 was for kids, and then the FDA approved Prevnar 13 for adults over the age of 50, but the CDC did not. The CDC did not endorse that recommendation. So the FDA said it was safe to give it, and it said it did respond serologically. It didn't say it prevented pneumonia. It didn't say it worked. It said that it produced a serologic response. So the recommendation now from the ACIP, the CDC, is to give it to people, kids under the age of 7, but to give it to adults only if they're immunocompromised, and that includes AIDS patients.
So what's the take home with that?
Well, what they're waiting for is a huge study that's being done in the Netherlands to find out the efficacy of Prevnar 13 in adults.
Okay.
And it's a $64,000 or 64,000 patient study. So they think they'll get a good answer out of that. What this shows is that the Pneumovax, the one that we relied on, is effective in preventing bacteremia, but it does not appear to alter the number of cases of pneumococcal pneumonia or community-acquired pneumonia. And I, what we say is, well, Joe Blow is at risk for pneumonia and therefore should get Pneumovax. What we should be saying is Joe Blow at risk for pneumococcal bacteremia?
So are we blank?
Because that's the only, that's apparently the only group that benefits from this.
Okay.
Now, one thing I think we can say, I'm sorry about the traffic on this slide, but what it shows is the power of these protein conjugated vaccines. So if you look at Prevnar 7 and look at serotype 14, which was in the vaccine and accounted for 49% of the cases in 1998, that went down to 0. I mean, that's amazing. And if you follow it out, even their grandparents didn't get pneumonia, and they didn't get the vaccine. I mean, they didn't get that serotype. So if you look out there for age 64, type 14, 40% before the vaccine, 4% after. And what that means is the kids are really the vectors. They're the ones. They're the ones that are the vectors of the pneumococcal infections. And now we've got, of course, Prevnar 13, and we'll have to see how that does in the kids. But the kids, vaccinating the kids may protect the adults. I mean, it may be that you don't have to give that to adults.
Right.
So here's the data on Prevnar 13, and I think I'll truncate this for the sake of time. Except to say the FDA has approved it, and therefore you're going to see it in advertisements. The CDC has not endorsed that as yet. Finally, I'm going to finish up by saying a little bit about new diseases and maybe a slide or two about the microbiome. The reason for the bat is thought to be the source of the new hot bug. But it's, there's only 2 cases, so we got to be a little bit careful. But it appears to be a coronavirus, and you are probably going to say a coronavirus. That's a cause of the cold, the common cold.
Right.
I mean, what a pathetic thing. And here's a man that died of it.
Wow.
Well, got to remember, SARS was a coronavirus. And also a zoonosis. And this is a zoonosis. And this is a patient who died, and there's another one who also died. So, one of the fun parts of infectious disease is these constant surprises.
Right.
And this is, all of a sudden, Legionnaire's disease. All of a sudden, SARS.
But what are you telling us about this case?
Well, I'm saying we got to watch. We got to watch it.
And there's 1 case?
No, 2. Same virus, same death. Both patients died.
Wow.
2 out of 2.
Wow.
So now we've got to really worry about. CDC has to watch this for this because the havoc that SARS created.
Right.
Oh, this shows its lineage, and I'm not going to dwell on this. I'll just say that darkened area is where this new virus is, and the SARS virus is just north of it.
Wow.
So it's very closely related to that one. I don't want to be overly hysterical about this. I think it's one of those things that is interesting to follow, and we need to follow. I'm not going. I think I'll probably just breeze through this because of time. This is a new disease. It's not a new bug. It's a new disease. It's a problem with autoimmunity to gamma interferon. And what patients get, first of all, they're almost all, with one exception, from Asia. They're all Asian born. And what they get are primarily disseminated mycobacterial infections. Now, they get other OIs, and sometimes it looks a bit like AIDS, except they don't get pneumocystis and they don't get Candida. They don't get thrush. So it's like AIDS without HIV. That's what it's like. Without
Wow.
PCP also. A lot of them. And this is
Wow.
a couple of cases showing skin lesions and bone lesions. This is not a good disease. This is a potentially lethal disease. Where they know about this is at the NIH, the clinical center. Steve Holland and that group are studying this.
So how
And
are they treating
If I
it?
had a patient that was Asian born,
Yeah.
had a mycobacterial infection, atypical mycobacteria, not typical mycobacteria, but atypical mycobacterial infection that was represented disseminated disease, I would probably then raise the specter of this as a possibility and have the patient or the patient's blood seen at the NIH. I would call Steve Holland.
Are there any treatments for this?
Yeah, I think it's riboxamine.
Okay, so they can.
Yeah, there is a treatment that they're using. Finally, I'm just going to say a word or two about the microbiome. To me, this is perhaps very early, but nevertheless very exciting because it's a whole new world for infectious disease. This is the microbiology of the various anatomical sites. So the body is a person who is demonstrating, like the red, you see a lot of red. That's Phurcomides. And the blue, you see a lot of blue. That's Bacteroidetes. Most of these organisms cannot be grown in the microbiology lab, but they can be identified by molecular techniques. This is the object now of the Microbiome Project, which is a $114 million project involving a large number of centers around the country in order to find out more about this. Now, I'm presenting this to you because it's early. However, it's early in its evolution. This has only been studied for a few years now. But I think there is a great deal of excitement about what we may learn. And so let me say a couple of things about this that I think are interesting or provocative. If you take the stool containing bacteria that we can't grow, but can recognize and identify by molecular techniques, if you take the stool from a fat mouse and put it into the colon of a germ-free mouse, the germ-free mouse grows up to be fat, have hypertension, hyperlipidemia, and diabetes, has the metabolic syndrome. And to me, that's just amazing. Now, how did the gut flora do that? The next one shows that if kids have extensive exposure to antibiotics, they are 4 to 5 times more likely to get Crohn's disease. I could go on and on with this, but please remember that this is kind of very early in knowing what this means in terms of our understanding of pathophysiology, but it may rewrite the books on a lot of these diseases, like psoriasis and autoimmunity and a lot of the cancers. The one at the bottom is the Helicobacter pylori, and people that have Helicobacter pylori have almost nothing else in their stomach. It's 95% of the bugs in the stomach. And of course, that predisposes to peptic ulcer disease, gastric cancer, malt tumors, reflux, and asthma. And that's just the gastric contents that is all driven by that bug that won the Nobel Prize. So at any rate, I think the microbiome is an exciting part. So when you talk about game changers, I think this is too early to call it a game changer, but it's got to be on the list because it's perhaps one of the most exciting areas of infectious disease. And I'll finish there, and thank you.
Okay, I think we have time for a few questions. We have a question here from Raymond Detali, and basically he is asking how the new hepatitis C drugs are working if with co-infected patients co-infected with HIV.
Well, we actually have 700 of them at Hopkins. So I have a big experience. You can use the drugs together, but it's complicated because of drug interactions. You can use raltegravir pretty easily with both boceprevir and telaprevir. I think we're going to be able to get around that. I think we're going to be able to treat co-infected patients almost all the time. But it will take a fair amount of finesse, and by that I mean it's going to take a provider who knows both diseases in order to be able to deal with all of the issues of the drug interactions, the resistance patterns, and the toxicity. What we worry about is toxicity, resistance to the new hepatitis drugs, and the drug interactions.
And have we seen that these new miracle drugs are going to work with if you have HIV?
Oh, yeah.
Okay.
Oh, yes. Oh,
Okay.
yes.
So
they still have HIV.
right. Okay.
Yeah.
But okay. And another person here, Ramon Ramirez, is asking how often you would recommend an immunosuppressed patient is vaccinated with Pneumovax.
Oh, the recommendation, it turns out to be a good question. Right now, if somebody's immunosuppressed, like the one you described, they should get both Prevnar 13 and Pneumovax. But the sequence is this. They get Prevnar 13 now, and then 6 weeks from now, they get Pneumovax. That's with the assumption that they haven't had Pneumovax for 5 years. If they've had Pneumovax in the last 5 years, they don't need that again.
Okay, and
It may be 6 months.
I'm going to see if I can interpret this question, but it says, how do you treat Hep C with cirrhosis? And I'm not sure if they're talking about the new drugs or presently.
Well, the patient that has cirrhosis, it depends to some extent on the fibrosis score, which could be by FibroScan or it could be by the FibroSure, it could be by the liver biopsy. That will define to some extent the probability of survival. And the urgency to get those drugs is based largely on the fibrosis score. That takes the knowledge of the liver part of the disease,
Right.
and that's going to be necessary.
Okay. And also, Dawn Pioso is asking, and I'm not sure which vaccination she's talking about, but I think you may. She says, have you seen in your practice patients testing a positive antigen for strep PN in urine 24 hours after vaccination?
No, I have not. But I may not be the right person to answer. Neil Halsey may be the better person to answer.
Okay. And my question for you, I have two questions. One is, we're running out of antibiotics. You've said this.
Yes.
Is anything being done to help with this pipeline, especially with this gonorrhea issue? I mean, what are we seeing any hope in new drug development? Are we seeing any initiatives to help us here?
Well, we've got 3 bills before Congress, but you know what that means. Mm-hmm. Congress can't seem to get stuff done. That deal with the collection of data like they do in Europe to foster incentives for drug companies. The one I love is one that would take patients who are a very select category because they have an organism which is resistant to all antibiotics available or failed everything.
Right.
And they would then be eligible for a trial that would be very limited. It would be limited to maybe 20 places or 20 patients. It's a smaller number. And we would get some background data. We would already have safety data.
Right.
We would have pharmacology data.
Right.
But we would do the test not in 2,000 patients like the FDA requires now, but we would do it in a much smaller number. Now that's currently is under discussion. Once it gets through that smaller number, then you could gradually, under a lot of oversight, expand the number to make sure that you really do have what you want. So in other words, you could actually get a product out on the base of a much smaller number of cases.
So that would basically be changing drug development in order to expedite these expedite
The one other
antibiotics.
thing that people might be interested in is the public-private partnerships, the PPP, and that's been very successful in TB drug development, and that's exciting. I won't go down there right now, but that's a partnership that's worth fostering.
Okay, so maybe we'll see that in some of these antibiotic issues. Well, thank you very much. That was fascinating and informative. Thank you, Dr. Bartlett. I would also like to thank Genentech and Cubis for their support of this very important education. And please remember to complete the quiz at the end of this session to secure your CME credits. I'm Rachel Gottbaum. Thank you so much for joining us.